Dr. Noel Wagner, the Saginaw-Tuscola Medical Control Authority. Today we're going to talk about Verapamil and its proper use. First off, why do we use Verapamil? The better drug or the more commonly used drug would be cardizem. Cardizem has a little bit less of an effect on blood pressure, so in hospital, cardizem tends to be used more. The problem with cardizem is it's not stable outside of a refrigerator for past 28 days. So we would be recertifying our 150 drug boxes every 28 days for a drug that didn't get used very often. So logistically, that's just we're just not able to do that within our system. So we use Verapamil. It's a calcium channel blocker. It slows down conduction through the AV node. It's been used for many years. It is a safe drug. Is also, you kind of have to say it's one of our most dangerous drugs, which doesn't make it an unsafe drug. It's just one of the drugs we have to be most careful with. And the key to that, and we'll talk about that in a little bit, is knowing when not to use it. Okay. So first off, if you want to see where it's referenced, it's Protocol 5.3. It's the tachycardia protocol. It's kind of an interesting protocol. It's one that the state came up. It has some of the elements that we had in some of our other protocols in the past. It's kind of quirky though. It says that it's meant for ventricular rates over 150 beats per minute. Then they go and they repeat that for SVT and a flutter of 150. But then when they talk about the atrial fibrillation, they say 125. They say 125 persistently. And I guess what they're trying to say is it's that your naders of your rates are above that, because we know how AFib will jump around. You know, people will report, I have a rate of 200, although it's 200, 150, 130, 200. That's not really 200 when it's bouncing around. The only way you're really going to know for sure what your rate is, it's a little tough off the monitor. You need to take somebody's pulse over about 30 seconds to get a true AFib rate. But we all kind of have a pretty good idea where we're sitting at with that. The key thing is use it with narrow complex rhythms. Everything we just talked about, SVT, A flutter, atrial fibrillation, it's all narrow complex. That's the key to that. So when do we not use Verapamil? We do not use Verapamil for hypotension. That's the number one thing. You have to have a systolic pressure of at least 100, if not 110, before you consider using Verapamil. Don't use Verapamil with hypotension. That's how you get into trouble. Unlike adenosine, which does some other things to the AV node, or at least the adenosine shuts it down for a period of time. Verapamil slows it down, but Verapamil stays around for a long time. It's going to be there for a bit. And so if you get the bad effects with Verapamil, you're going to have to deal with those bad effects for a while. So number one, no hypotension. Make sure they have good blood pressure. Two, don't use it for wide complexes. If you're above 120 or 3 boxes, don't be using Verapamil. At a minimum, we should talk on that, but probably going to say no. You have to be very careful about ventricular rhythms. Verapamil, indium calcium channel blocker with a wide complex ventricular rhythm is a very bad idea. So stay away from that. Number 3, you'd think this would go without saying, sinus tach. Make sure it's not sinus tachycardia. We don't want to slow down sinus tachycardia. That's usually reactionary. The primary problem isn't the sinus tach usually. It's usually because of something else, dehydration, blood loss, sepsis. We don't want to slow that down. You got to make sure it's not sinus tach. The machines are pretty good at reading sinus tach. Our monitors are, but they will miss it sometimes. Especially if the machine's not seeing a P wave in V1 or V2. A lot of times it'll just assume there's no P waves, where when you look at the rest of the EKG, you can very clearly see that there are P waves in other spots. So make sure that the rhythm really is what you think the rhythm is. It's not sinus tach. It's narrow complex, and it's one of the other ones we talked about. All right, so that's when not to use it. If you notice, it's not in the PEDS protocol. Verapamil is not a pediatric drug. It's not there. It's not on our pediatric cards. So we should be using this in adults. If we ever were to consider it in somebody under 18, again, we should be talking. It might be the right drug in somebody with SVT, as a teenager, but that's infrequent enough use that we should talk on that one. And finally, how much do you give? When we were doing the Verapamil protocol, prior to the state protocol coming out, we were doing 0.1 mg per kg up to 10 milligrams max. That's the listed dose of Verapamil. The state protocol that we have in place right now lists up to 5 milligrams as the maximum dose. I'm okay with that for right now. We'll let that ride and see how it is. 5 milligrams. If you get 10 minutes after you finish your dose of Verapamil and you think they need more, give me a call. We'll talk about it. That helps me keep an eye on when we actually do need a second dose, and it kind of helps us, get our bearings as we start using this drug more. So that's Verapamil in a nutshell. Again, go back over the key reasons when not to give it. No hypotension, no wide complex, and no sinus tachycardia. If you stay away from that, you're going to find that Verapamil works really well. When they get to the hospital, expect them to start a Cardizem drip. Not going to get a Verapamil drip. That's perfectly fine for them to switch over to another calcium channel blocker. So hopefully that answers some questions on that. Thanks for joining us today.